Respected Chairperson, Dr. Sharad Glib, Assistant Professor, Department of Psychiatry, All India Institute of Medical Science, Guwahati. And today's speaker, Dr. Rahul Ganesh, Assistant Professor, Department of Psychiatry, JIPMER, Pondicherry. And today's moderator, Dr. Ashwath Babu, Dr. Vasugi, Consultant Psychiatrist of Sneha Mindcare Hospital, Tirunelveli. And my practicing psychiatrists and postgraduates, very good morning to all of you. I extend my warm welcome to all of you for this Evolve webinar on this Sunday. Indeed, it's a great privilege for me to organize this All India Evolve PG webinar. And we have been conducting this Evolve webinar almost for more than for the past 2 years. We conducted this webinar on every fourth Sunday. There is a overwhelming response and support for these webinars among the postgraduates and also among the practicing psychiatrists across India. And we are choosing the topic which is more relevant for the postgraduates. And the speaker is also for this webinar is a well-known and eminent personality. And the chairperson is also a senior postgraduate teacher. And the webinar is not only beneficial for the postgraduates, but it's also refreshing for the practicing psychiatrists. I am thankful for Dr. Sharad Glib, today's chairperson, and the speaker, Dr. Rahul Ganesh, JIPMER, Pondicherry, for accepting our invitation and joining this program in spite of this busy Sunday. And today's speaker is Dr. Rahul Ganesh. He is from JIPMER, Pondicherry. We all know that JIPMER is one of the premier medical institute in India, and is an eminent postgraduate teacher. And Dr. Rahul Ganesh is going to speak about one of the most important topic, that is negative symptom in schizophrenia, assessment and management. I hope this topic will definitely use for the postgraduates and also for the practicing psychiatrists. The speaker will ask 5 questions during the presentations. The first and quick response will attract attractive prize, and all the postgraduates will enter your answer in the chat box. The postgraduates won the last quiz will be announced by the moderator, Dr. Ashwath Babu. This moderation, I hand over the session to Dr. Ashwath. Over to you, Dr. Ashwath.
Thank you, sir. Very good morning to everybody here. A warm welcome to all participants joining us today for the Evolve Psychiatry lecture series. We are delighted to host you today. We have participants from across the nation. Myself, Dr. Ashwath Babu, currently working as consultant psychiatrist at Sneha Mindcare Hospital, Tirunelveli. I'll be moderating today's session. First and foremost, I would like to express my sincere gratitude to our course director, Dr. C. Panniselvan sir, director and senior consultant at Sneha Mindcare Hospital, whose vision and dedication have made this lecture series possible. Thank you, sir, for giving me the opportunity to be part of this great initiative. Move on to introduce our esteemed chairperson for the day, Dr. Sharad Philip, sir. Sir is currently a faculty assistant professor with the Department of Psychiatry, AIIMS, Guwahati. He has completed his MD in psychiatry from prestigious NIMHANS, Bangalore, and trained further in psychiatric rehabilitation and the community psychiatry. He has completed his MBBS from CMCH, Ludhiana, Punjab, and then a PGDFM from CMCH, Vellore, Tamil Nadu. He has completed his PG diploma in medical law and ethics from NLSIU, Bangalore. He has published many articles in reputed journals at national and international level. He holds editorial position in CAPMH, Child and Adolescent Psychiatry and Mental Health, BMC Public Health, and JPRMH. His interests include psychiatric rehabilitation, neurodevelopmental disorders, alongside psychotherapy training. Sir, we are truly honored to have you with us today. Now I humbly request you to introduce the topic for the day, sir. Over to you, Dr. Sharad Philip, sir.
At the outset, thank you so much for the kind introduction, and also a great shout out to the organizers. You've been running this for the last 2 years, and I am really happy that this is being taken across the nation. Today's topic is a very relevant topic. It's something that we also grapple with during our training, and we try to understand what we can do, because at the end of the day, this is the single most important determinant of functional outcomes, along with the positive symptoms and cognitive symptoms. We've learned a lot about schizophrenia. It's one of the most enigmatic illnesses that is there within psychiatry. But what stays for the longest are these cognitive and negative symptoms. So without further ado, I would like to request our speaker for the day to talk to us and tell us about negative symptoms of schizophrenia, the recent advances, the assessments, conceptualization, and management. What he's going to tell us is going to be very relevant, especially for our practice in India, knowing fully well that the burden of functional outcomes and any rehabilitation related processes is solely put on the families in India today. There's not much that can be done at the level of an institution. There's not much that is done in terms of public health for these aspects. So here, as the next generation of psychiatry residents, as next generation of psychiatrists, it's for you to start thinking, brainstorming, thinking of innovative delivery models, and look at what works. Maybe it's not one intervention. Maybe it's a multi-component intervention. Maybe it's not negative symptoms at all. It's not so negative. Maybe it's something a little bit more functional. Maybe it's got to do with the environment. All of that, let's get it clarified, and let's get Dr. Rahul to tell us more about that. Back to the moderators. Thank you so much.
Thank you, sir, for your insightful prelude about today's session. Now moving on to speaker introduction. Dr. Rahul Ganesh, sir, is currently working as Assistant Professor, Department of Psychiatry, JIPMER, Puducherry. He has an MBBS degree from Government Medical College, Tirunelveli, Tamil Nadu. He has completed his MBBS from All India Institute of Medical Sciences, New Delhi. He also holds a DNB degree. Sir is currently the chairperson of Website Subcommittee of Indian Psychiatric Society. He is also the convener of Website Subcommittee of Indian Association of Child and Adolescent Psychiatry. He is a peer reviewer at Indian Journal of Psychological Medicine, Indian Journal of Psychiatry, Journal of Dual Diagnosis, Indian Journal of Social Psychiatry, Journal of Indian Association of Child and Adolescent Mental Health. Sir has many honors and awards to his credit, which includes Dr. J.K. Trivedi Award, Dr. B.B. Sethi Award, and V.K. Verma Award in the National Conferences of Indian Association of Social Psychiatry. His area of interest include neuromodulation, child psychiatry, addiction psychiatry, and telepsychiatry. Sir, we are delighted to have you with us today. I now welcome you to deliver the lecture. Over to you, Dr. Rahul Ganesh, sir.
Thank you for the warm introduction. Thank you for this opportunity to present in Evolve, and I am happy to be associated with Tirunelveli for the first time. So, this is my hometown, and it's very warm to present in a series which is associated with Tirunelveli. So I'll start with the presentation. If there is any difficulty in audio or something, please let me know. So okay. Yeah. So today's topic is about the negative symptoms in schizophrenia assessment and management. We all know that schizophrenia is a chronic disabling disorder, and it has a heterogeneous constellation of positive and negative symptoms. What is negative symptom? Negative symptom basically reflects there is lessening or loss of normal behavior or functioning in patient. It also reflects the abilities or the senses that are lost due to the disease. It involves restricted emotional expression, reduced productivity of thought, and multiple things. But it accounts for the large part of long-term disability and poor functional outcome in patients with schizophrenia. It covers basically these 5 domains, including blunted affect, which is decreased expression of emotion, alogia, which is a decrease in the reduction in the quantity of thoughts. Spoken evolution, which is decreased, reduced initiation or persistence of goal activity due to decreased motivation, asociality, and anhedonia. And we know that all these symptoms are persist. When we compare with cognitive deficits and positive symptoms, this have a worsening course, and they persist for long duration of time, and they are directly associated with the disability in patients with schizophrenia. Studies have shown that about 90% of patients in the first episode itself have negative symptoms. And even after treatment, 35 to 70% of patients have persistence of the negative symptoms, which is very, very difficult to manage. And most common negative symptoms include social withdrawal, emotional withdrawal, and poor rapport. One of the largest study, which is the CATI study, we all know, which is clinical antipsychotic trial of intervention effectiveness, have shown that about 40% of patients have negative symptoms. And there are different concepts like prominent negative symptoms, predominant negative symptoms, which we will be seeing in the course of this lecture. Were also persistent in this study. This is actually based on neurology. It is not psychiatry. In neurology, in this the distinction between the positive and negative symptoms originated in the field of neurology, and then we adapted it in psychiatry. he gave the term positive neurological symptoms, which is actually excess of vital properties. And these are the abnormal superimposed behavior present in patients with epilepsy. And this includes hallucination and paranoid delusion. And negative neurological symptoms are considered as negation of vital properties, which is loss of sensation, paralysis, and coma. So then further, this was first described in 1861 in his work in epilepsy. And further, there were other people who worked on it. So Herbert Spencer is a person who gave this dissolution and evolution of nervous system. And Hughlin Jackson, Berrios and other people mainly attribute the development of negative symptoms to Hughlin Jackson's work, where he extended the Spencer's idea to positive and negative symptomatology, where negative symptoms are basically dissolution of neuronal functions, and positive symptoms are excitation or release of lower level from the higher inhibitory control lead to positive symptoms. So these were the people who were associated with the origin initially. Then came this other people, including Crow and Nancy Andreasen and William Carpenter. So Crow is famously attributed to the negative symptoms, but he gave this two concept where there are two dimensions of pathology underlining schizophrenia. One component being an reversible and neuroleptic responsive component, another component being a progressive, relatively irreversible component, and is associated with the deficit or negative symptoms, which is type 2 syndrome. And he gave these two components, including type 1 and type 2, where type 1 is mostly positive symptoms, having hallucination, delusion. It is involved in acute schizophrenia. It has good response, reversible, intellectual impairment is absent. And there is increased dopamine receptor as a postulated pathological process. There is another pathology, which is type 2 component, which involves negative symptoms, including affective flattening, poverty of speech, loss of drive, and it is a chronic schizophrenia with a defective state and a poor response to neuroleptic, may be irreversible outcome. And sometimes they can present with intellectual impairment, and there is a loss of cell loss and structural changes in the brain. So this is the initial nosology that came up. Then whatever we are reading now is the pioneering work by Nancy Andreasen. She explained in detail about the negative symptoms of schizophrenia, and also William Carpenter, who worked on gave the concept of the deficit syndrome, where there are he gave based on the DSM-5 criteria, there can be at least like he gave there are three negative symptoms, out of which two should be present, including the restricted affect, diminished emotional range, poverty of speech, curbing of interest, diminished sense of purpose, and diminished social drive. And like maybe there are other also terms associated with this, including deficit syndrome, predominant negative symptom, prominent negative symptoms, and persistent negative symptom. Where deficit syndrome is the one where all the symptoms persist for a period at least in the preceding 12 months. And there is another concept named predominant negative symptom, where the negative symptoms occur alone or in greater relative severity than the positive symptoms, which is actually used in most of the researchers in patients with negative symptoms. Because to see the response, we have to include those patients with predominant negative symptoms. And there is another concept called prominent negative symptoms, where it is clinically relevant but does not have a clear prominence. It occurs along with positive symptoms. And then persistent, enduring negative symptoms, where it can be both positive, primary or secondary negative symptoms, but they have poor response to treatment and they are persisting for more than 6 months, and they persist even during the period of clinical stability. The patient is presenting with the 2 out of this 6 condition, including restricted affect and poverty of speech, and it's present for the past 12 months. Though it is not a diagnostic, like it is not mentioned as in diagnosis in our ICD-11 or DSM-5, it is a very relevant thing for research purposes. So then comes the concept of primary negative symptom and secondary negative symptoms. Primary negative symptoms are the one which are intrinsic to the underlying pathophysiology of schizophrenia. And there are secondary negative symptoms which are related to other factors. It can be due to the psychiatric condition, or it can be due to the medical comorbidities, or it can be due to medications, side effects, or due to environmental deprivation, or treatment or illness-related factors. So the affective symptoms can be comorbid depression, anxiety, anything that is comorbid in the patient with schizophrenia can present as negative symptoms. So essentially we have to rule out these things, because secondary negative symptoms are usually treatable when we are managing the primary condition. But when it is a primary negative symptoms, it is difficult to treat, for which further assessment is required. So secondary negative symptoms, if a patient is presenting with a delusion of persecution, which is a primary psychopositive symptom, because of the secondary effect, they can be socially withdrawn. That can be a secondary negative symptom. Or because of the overwhelming stimulus that they are getting, they have difficulty in coping with the problem, they can have a diminished expression. It can be a secondary negative symptom. So treating the primary would be a main thing for this kind of conditions. Well, then what is the mechanism for the primary negative symptoms? There are different mechanisms postulated. One is dopaminergic hypothesis of schizophrenia, where it says positive symptoms are due to hyperactivity of the dopaminergic neurotransmission in the limbic pathway, while the negative symptoms are due to hypodopaminergic functioning in the frontal lobe and mesolimbic structures. So people have done various animal studies have repeatedly proven this one. Apart from that, there is another hypothesis, which is a glutamate hypothesis, which is demonstrated by like various experiments where when there is a chronic blockade of glutamate neurotransmission by antagonist at the N-methyl deaspartate receptor subtype, we have a pathological state which actually resembles schizophrenia, which includes both positive and negative symptoms. So both dopaminergic and glutaminergic hypothesis holds valid, and these are very important for management of negative symptoms in with like whatever the mechanism of action of the drugs which we are working based on this. And another important dopamine receptor, most of the dopamine D2 receptors are usually there for the positive symptoms. For dopamine D3 receptors are actually important for management of negative symptoms. Because of its localization in the mesolimbic region, it controls reward, emotion, motivation, and it is involved in modulation of negative symptoms, mood, and cognition. And animal studies have shown that antagonism and partial agonism at the dopamine D3 receptors mediates improvement in social interaction. And D3 receptor mediated anhedonic effects are also seen in animal models. And dopamine D3 receptors are also involved in increased acetylcholine release and regulation of glutaminergic excitability in the prefrontal cortex, and also regulation of dopamine and CREP phosphorylation and gamma oscillation in the hippocampus. So basically, these three mechanisms are we have to remember while management of patients with negative symptoms. So while in the assessment, we have to focus on the patient's level of interaction, their interest in and their engagement with various activities. They have to evaluate their bodily language, facial expression, gestures, eye contact. We have to assess the patient's daily activities. We have to question about their social activities, their hobbies. And we have to do n number of things, like including psychiatric and medical conditions, assess the medication side effects. There is no single thing. We have to compare the patient to what is expected from them of if a person is of healthy age and sex, what they will be doing. We have to compare accordingly. So basically, it is difficult. So we need various different schedules for management of assessing, which is the first instrument developed to assess, like comprehensively assess patients with negative symptoms. It has 5 different subscales, including alogia, affective blunting, evolution apathy, anhedonia, asociality, attentional impairment, and there is a global severity rating scale also. So every one of us use this scale. We need not we need not discuss much about it. And another one scale that we commonly use is a PANASYS, which is positive and negative syndrome scale. PANASYS is most commonly used. It has 3 different subscales. One is for positive, one is for negative, and one is for general psychopathology or cognitive psychopathology. And the negative scales has 7 subdomains, including blended affect, emotional withdrawal, poor rapport, passive or apathetic social withdrawal, difficulty in abstract thinking, lack of spontaneity and flow of conversation, and stereotypic thinking. But apart from that, there is a scale for deficit syndrome also, where the 6 different criteria are there for deficit syndrome. Each are scored from a severity of 0 to 4, and if the score is more than 2, if in 2 of the 6 symptoms, then we can rate the patient to have a deficit syndrome. But these are like this is not most commonly used. Like we commonly use SANS and SAPS and PANASYS. But what are the new skills that are available? One such scale is the 16-item negative symptom assessment scale, where different items are there, and this is given by ALPS and group. They have given different items, 32 items, 16 item, and 4 item. 4 item one is most commonly used, which is they picked up only 4 different domains of the 16 item one. where second domain is the restricted speech quantity, and fifth domain, which is as emotion, where reduced range is assessed, and reduced social drive or reduction in hobbies and interest. This 4-item one is very short, which can be used very commonly in clinical practice to assess the negative symptoms. And another one, which is a recent one, is clinical assessment interview for negative symptom. It has 13 items, and it divided into 2 subscales, where 4 items are for expression, including facial expression, vocal expressions, gestures, and speech, and 9 items for emotion and for assessing motivation and pleasure, including social, work, and other recreational activities. And the recent one, which is developed after the like National Mental Health consensus, to develop that something is missing in all the scales which are previously available. And they have found out that like apart from the 5 domains, there has to be a 6th domain that has to be assessed for patients with negative symptoms, which is the second one, which is the distress, lack of distress, which contains the 5 items that are already there, and the 6th domain, which is lack of distress, which points to the one's emotional functioning in more depth and one's ability to experience not only pleasurable but also unfavorable circumstances are also assessed by this domain. So this is in brief about the various assessment things available for patients with negative symptoms. But for management, what we can do? So one of the most important thing we have to do is early reduction and treatment of psychosis, because when the duration of untreated psychosis increases, it'll be difficult to treat the negative symptoms. And meta-analysis have proven that those who have a shorter duration of untreated psychosis have better improvement in the negative symptoms. And another important concept that people are saying is lower to medium doses of antipsychotics may be most effective for treating negative symptoms. If a patient is presenting with negative symptoms, we have to optimize the dose. They might be over medicated. We have to maintain them on a medium effective dose, which is required for the patient. It's relatively less for others. Meta-analysis of all the antipsychotics have shown that amisulpride was superior to placebo, and it has a good effect size, but also other drugs like olanzapine was superior to haloperidol managing negative symptoms. And recent studies have shown that cariprazine is actually overperforming other drugs. So once a study is published in Lancet, which is the largest prospective study, and it is randomized double-blind, and they have included only predominant negative patients with predominant negative symptoms and without relevant depression or extrapyramidal side effects. And they assessed it for 26 weeks and found that a fixed dose cariprazine of 3 milligram, 4.5 milligram compared with risperidone, cariprazine was found to have improvement in patients' negative symptoms when they are including only the factor subscore of negative symptoms in PANASS, and found that it is working well. So current whatever the evidences we are getting more evidences for cariprazine also, apart from amisulpride. And also clozapine. Clozapine is used for treatment-resistant cases, and meta-analysis in patients who are on clozapine compared with other medication have shown that clozapine was superior both for positive and negative symptoms in the short term, but in long term, the superiority of clozapine is comparatively less for negative symptoms, and it is more superior only for the positive symptoms. So among the medications, we know second generation are better than first generation, but all these 3 medications are known to be effective in patients with negative symptoms. So all this this belongs to different classes of medication. One such thing is N-methyl deaspate receptor modulator, where it can act through both the direct agonist or indirect modulator pathway. Direct agonists are D-serine or glycine, which acts through the D-serine or glycine receptors of NMDAR. And there are certain indirect modulators which increases the level of D-serine and glycine, like glycine transporter inhibitor. Eclipiritin is one such drug, which is actually not FDA approved, but it is approved. It has a breakthrough therapy designation currently as of now, and prospectively it might get approved for management of schizophrenia. And another this medication is D-amino amino acid oxidase inhibitor, which is luodexstat. And all these medications, it is not only currently they are tried both for positive and negative symptoms of schizophrenia. And other glutamate modulators include D-cycloserine, which is partial agonist at the D-serine or glycine site of NMDA receptor. Mementin, which has selective antagonism at the extrasynaptic receptor. and N-acetylcysteine, which is actually a glutathione precursor. It acts through a different receptor site in the NMDA receptor, which is a glutathione sensitive site, and based depending upon its action, it modulates the activity. And metamotropic glutamate receptor agonist, which is also commonly used, in trial nowadays. And evenamide. Evenamide is an inhibitor of voltage-gated sodium channels, which attenuates the glutamate receptors. It is actually currently in approval phase for the DRS phase 3 developmental program. And if evenamide get approved, we might actually get a new medication compared to Clozapine for treatment-resistant schizophrenia. But currently, as of now, it is not approved. And there are other mechanisms of action, including serotonin receptors. Currently, we are commonly using this drug, mainly pimavanserin. And also, there are people are actually coming up with lumateperone and other drugs. All these medications have actually shown a good effect size in management of patients with negative symptoms. Ondansetron, which is most commonly used for vomiting, it can act through reduced activity of GABAergic interneuron subtype. It can increases the level of activity of parvulmin, and by improving the excitatory inhibitory balance, it can improve the negative symptoms. And also, there are other drugs, including phosphodiesterase inhibitors, including celestol. Phosphodiesterase 10A inhibitors are most commonly tried nowadays for negative symptoms, but also phosphodiesterase 3 inhibitors and phosphodiesterase 4 inhibitors are also tried for patients with negative symptoms. Antidepressants. Most common practice in our clinical thing is after optimizing the dose of antipsychotics, we usually try antidepressants. We try to give something. If the patient is having secondary negative symptoms, definitely it will work. But for primary negative symptoms also, meta-analysis have shown that it has a small to moderate effect size. Common drugs include SSRIs, including sertraline, fluoxetine, have been tried. Apart from that, mirtazapine, duloxetine, or ortioxetine are also shown to be effective in patients with negative symptoms. Apart from these medications, there is also medications like pro-dopaminergic modulation, because we have seen in the hypothesis, hypodopaminergic activity is related to negative symptoms. So studies have shown that modafinil and armodafinil, there are 4 or 5 studies which have shown that in patients with prominent negative symptoms, they are found to be statistically significant and have although there is a small effect size. So everyone has answered rightly. Like xanomeline is recently approved, which is an M1, M4 receptor agonist for management of schizophrenia. It is approved in combination along with trospium chloride, which is actually a peripherally acting anticholinergic. And this combination is actually approved for recently, last year. And it acts through modulation of this M1, M4 receptor. And it acts through both the mechanism that we have seen in patients with schizophrenia, both dopaminergic transmission and glutaminergic neurotransmission. So all these things are welcoming changes that are happening. And if they work, we will be able to better manage patients with negative symptoms. And there is nicotine pathways also established in patients with negative symptoms. So nicotine alpha for acetylcholine receptors agonist like N-cyclin is also used, where it has got a fast track approval for in FDA for cognitive improvement in schizophrenia. Apart from all these medications, we have anti-inflammatory agents like aminocyclines, NSAIDs, raloxifene, and neurosteroids, which have been tried in patients with management of patients with negative symptoms. So this is with medication. So apart from medications, what else we have for management of negative symptoms? One is neuromodulation. So among neuromodulations, we have transcranial magnetic stimulation and TDCS, transcranial direct current stimulation. In transcranial magnetic stimulations, people have tried both low frequency, high frequency, and theta burst stimulation for management. But there are only meta-analysis not available for theta burst stimulation. When I searched, I could found like there are few meta-analyses which are available for like high frequency stimulation. People have focused on the left dorsolateral prefrontal cortex and high frequency stimulation of more than 1 hertz. Like the most commonly used is 10 to 20 hertz at an intensity of more than 100 motor threshold. It can be 110, 120 resting motor threshold have been used, targeting left DLPFC. And the usual duration of session is for around 3 weeks. And the possible mechanism is by correcting the alleged hypoactivity in the DLPFC region. Apart from transcranial magnetic stimulation, we have direct current stimulation, where anodal transcranial direct current stimulation is applied at the left DLPFC to enhance the excitability of the neurons. And most common stimulation parameters are used are 2 milliampere current, and the session is applied for 10 sessions, and the usual duration is given for around 20 minutes. But the effect is variable, because though anode they have applied on DLPFC, cathode they have applied on different regions, including temporoparietal region, junction, or right DLPFC. So the evidence is not that much robust for TDCS. So apart from medications and TDCS, the most important and thing that can be do in a day-to-day practice is psychosocial interventions. So among the psychosocial interventions, first and foremost is the physical activity, because meta-analysis have clearly shown that 90 minutes of moderate to vigorous exercise per week are found to have a small to moderate significant effect on the improvement of negative symptoms. And apart from like vigorous exercises, aerobic exercises, including endurance training, cardiovascular exercises like treadmill, walking, and yoga, are also found to be effective in patients with negative symptoms. Another one important aspect is cognitive behavioral therapy, because like the several psychosocial variables, including defeatist belief, negative expectations or low expectations about their self, or asocial preferences, are seen in patients with negative symptoms. This is the cognitive schema I could get from like one of the article, where it shows that negative symptoms including evolution, anhedonia, apathy are associated with different cognitive like variables, including perception of limited resources. I don't have any concentration, or I attach very little importance to close friends. So there is defeatist belief. If I cannot do sometime well, I can't do anything at all. So multiple things are there. Though it's difficult to get from patients, it can also associate with secondary negative symptoms, but we can work on this. And there can be certain beliefs and behaviors associated with this. By making the patient more aware about their patient's thoughts, behavior, and feelings, we can make an effort to change all these negative symptoms in patients through CBT. Another one, which is most commonly tried both for cognitive and negative symptoms, is cognitive remediation. So it is also found to have a moderate effect size, but among the psychosocial interventions, only these three I found to have an clear effect. But apart from that, there is assertive community treatment, involvement of family in the treatment, and social skill training are also found to be very effective. But the first and foremost thing is we have to use different strategies to reduce the duration of untreated psychosis. If the duration of untreated psychosis is increasing, negative symptoms will worsen, and then there will be difficulty in management. So this is in total about summary about the management of negative symptoms. Thank you.
Thank you, Dr. Ganesh, for a very lucid and extremely coherent presentation. You have given us a very great overview, the eagle's eye perspective of all the interventions that are available, all the way from pharmacological options to what's there in trials and what is being investigated. Along with that, you've touched on neuromodulation and some strategies there, what's got evidence, if any, and as well as you've touched briefly on psychosocial interventions too. It was extremely engaging. Your slides were very commendable way of communicating the information. So I just wanted to kind of add a few more words to what you had mentioned. I think some things that I could just think about when you were presenting was about in India, when we are looking at negative symptoms of schizophrenia, it's very I mean, in the clinic, if we just do an experiment like in our clinic, how many of the people with schizophrenia come with negative symptoms? So, or how many of the caregivers come and complain about that? A lot of times, what's happening is these are people who are getting missed out. These are people who are not coming to the clinics because for them, it is that, yes, the doctor has written medications, this you are taking with those medications, and now he's not doing his effort, or the patient is not doing what their part is. So there is a lot of stigmatization and there's a lot of internalization of these negative symptoms as being behavioral, as being related to the personality or the deliberate. There is a connotation of a deliberate nature to the patient, to all of these things, which is actually not the case. This also leads to the development of a lot of expressed emotions, a lot of criticality, a lot of hostility sometimes, there's a lot of coercion and violence against patients. They're told to, okay, you're not going to eat. And, then these things result in a lot of other things like violence from the patient as well, substance use, those kinds of things. And there's deprivations that they try. Then the family kind of reaches an equilibrium. Okay, if I just don't tell anything, this is how it is. I just have to ignore. I may consider my patient as some sort of a space-occupying lesion in the home, and that's about it. I don't have to do anything about it. So this equilibrium is something that is quite detrimental for the long-term outcomes of schizophrenia. And it also kind of compels me to think, when we used to talk about the IPSS study, one of the first studies that told that schizophrenia around the world is very, very similar. They started telling that, people in India, in low middle income countries, schizophrenia has better outcomes. Now, that gets you wondering, are people in India not experiencing negative symptoms, or are they experiencing it to a lesser degree? Or is it that that we're not picking it up at all? Is it that these people are not coming to the clinics? Or is it that the families have internalized this problem and not done anything about it? So this is one question that I would like you all in attendance to think about, because this is the core of most of the rehabilitation that we do in India. We have very few centers that look at trying to help with negative symptoms. Another thing here, very important thing, when we look at the treatment resistance criteria, we don't see criteria for negative symptoms directly. We can see in the Keynes criteria that there's a talk about the psychosocial functioning, and the outcomes having been impaired for a period of 3 to 5 years. But that's just a proxy. There's no measure of the negative symptoms as a mandatory criterion within treatment resistance. Now, the states that Dr. Rahul was mentioning about predominant negative symptoms, where, they seem to be predominating over the positive symptoms. You've treated the person, he's responded very well to risperidone, but there are persistent negative symptoms. What do you do? Do you then switch to clozapine? Do you then think of, okay, importing xanomeline and trospium? Or what do we exactly do here? So what's available for us? Even neuromodulation is a pipe dream. Even in the metros, you don't have good penetration for these things. But what's available for us are simple psychosocial interventions which are there. Now, things like activity scheduling, day programming, daycare services, things like supported education, employment, all of these, they seem to have some benefits over there. So, of course, you're looking at the psychosocial outcomes, and you're also doing a psychosocial intervention. So, you tend to say that, yeah, because I've given this intervention, this outcome has to be better. So that's the critique over there. But if you look at it, most of these interventions, they're all focusing on getting the proband, getting the sufferer to do certain things repeatedly. So be it activity scheduling, be it day programming, be it going for employment or education, or even if you look at cognitive symptoms, when you're trying to do something like cognitive remediation work, all of these are trying to get them to do things repeatedly, which goes back to trying and saying that, okay, there is a need for us to strengthen those circuits. And, motivation can be addressed through some way by repetitive emphasis and repetitive efforts on these lines. That said, I think historically, I was wanting to check with people here, if there's anybody they can just tell about what was simple schizophrenia. Simple schizophrenia was a subtype which was told some time back in ICD-10. Anybody here knows about this, especially the audience and the junior residents in training? I don't know how we would like to respond. You could probably respond in the chat, or you could unmute if the organizers allow you, and explain what simple schizophrenia is. Thank you so much to the organizers. Back to you, Dr. Ashwath and the organizers.
Thank you, Dr. Sharath Philip sir and Dr. Rahul Ganesh sir for the excellent session, for chairing the session and for giving the excellent lecture, sir. Proper Sunday feast, I would say. Now moving on to the conclusion, I request Dr. Paneerselvan sir to give the concluding remarks.
Thank you, Dr. Ashwath. Thank you, Dr. Rahul, for your wonderful, very informative presentations. As we know that with the past, we have a first generation psychiatrist and psychotic when I joined my MD. After that, we gradually come across a lot of second generation psychiatrists, which very much reduce the negative symptoms. But still, negative symptoms are one of the major factor for the functional abilities. Mainly it affect the occupational impairment. So when I was the president of Tamil Nadu IPS, so we started a novel program called the Employment Exchange for entire Tamil Nadu Psychiatric Society. Actually, it was the SCARF and some Chennai psychiatric clubs. They do it in a very small level. So we want to expand it in a pan-Tamil Nadu level. So when I was the president, we purchased a house for Tamil Nadu IPS exclusive at Chennai, and we modified that. We termed that house to be as a office for employment exchange. So we are working on that employment exchange. Probably, I think that along with the medication, we have to focus on psychosocial intervention also. So many of us, we are focusing only on medications. We are ignoring the other aspect. The psychosocial is very, very important, especially social skill training, vocational rehabilitations, and assessment. That's very, very important. And in Tamil Nadu IPS, we're working on that. So I think that we started in Chennai. Probably in other part of Tamil Nadu, we are expanding the employment exchange. Probably we'll be planning to publish also in subsequent months. Work is going on. And thank you, Dr. Sarathpuri, for sparing your valuable time to share this session and also for your input. I thank my colleague, Dr. Ashwath Babu, and all the participants for active listening and participation in the discussion. The YouTube link will be available for the previous session, and current session is there. So if you want, you can ask the East-West Pharma for more details. My special thank to the sponsor, the East-West Pharma. With the East-West Pharma, what of thanks, I think you can conclude the session. Over to you, Naveen.
Thank you, doctors. So I'm so happy to conclude this session with the great speaker, Dr. Rahul Ganesh has given us a lucid presentation for benefit of the pages. And also I extend my gratitude to Dr. Sharath sir to immediately accepted our invitation as a chairperson. And also consistently we are doing for the past 2 years because of our course director, Dr. C. Paneerselvan sir. And we published a first series book also, doctor. So it is reaching across all India, all medical colleges. We are distributing 2 books from our Evolve first series, and forthcoming series also it is going to start now. So this is not only as a webinar, the same content will be delivered as a booklet for the book series for the benefit of the medical college students. So we are so happy. East-West Pharma is always committed for such academic initiatives, and thank you very much. So today the attendance we crossed 125. So it's nice to see we never reduced 100 attendance. So it seems that the result, the winners list itself seems that it's reaching across India. So thank you very much, doctor, and thanks for giving such a wonderful program and successful program for our benefit of the pages. Thank you, doctor. Have a great day to all.
Thank you to all. Thank you.
Thank
The
you.
exam is going at Tamil Nadu.